Hello, welcome to Facing Mpox, Tackling Stigma, a virtual town hall. My name is Christian, and I will be your moderator this evening. This event is being presented by the Pride Center at Equality Park, located in Woodton Manors, Florida. During this town hall, we will not be taking questions. However, there is a chat window where we will be posting links and other relevant information. As you will hear today, Mpox interacts with other diseases, including HIV. Since the Pride Center has programs related to HIV testing, we are putting a link in the chat box for anyone with a Florida address to order a free home HIV test kit mailed in a plain brown box. We encourage community members to know their HIV status. If you live outside of Florida, you can contact us for information on how to obtain a free home HIV test kit. Our contact information is at this same link. In order to help us understand the impact this town hall has, we're going to begin and end the town hall with a poll. We'll be asking attendees the same questions now and then again at the conclusion of the town hall. We'll pause for about a minute to give you time to respond to the polling questions you see on your screen now. Okay. Thank you for your poll responses. And now I would like to turn it over to Mr. Robert Boo, the CEO of the Pride Center at Equality Park.
Hi, everyone, and a warm virtual welcome to all of you joining us. Thank you for being a part of this very important town hall. So, who is the Pride Center at Equality Park? Let me give you a little bit about ourselves. Our mission, we provide a welcoming, safe space, an inclusive home that celebrates, nurtures, and empowers the LGBT communities and our friends and neighbors here in South Florida. The center's history, we started back in 1993. And as most community centers started, we started in someone's literal living room with a bunch of community members coming to address the HIV pandemic that was going on at the time. Over the course of the 30 years, we've grown, we've added to our services and programs, and we've actually moved around and ended up on our current 5.5-acre campus. The Pride Center offers a large portfolio of services to the community, including in-person and home kit HIV testing, linkage to HIV prevention and treatment, wellness services, including smoking cessation and stress management. We have the nation's largest weekly gathering of active agers. Our Women with Pride program has an LBT health directory that links the LBT community with culturally proficient service providers. Our transgender services links people of trans experience, again, with culturally proficient service providers in South Florida. And then we also offer a free cyber center to allow our community members to stay connected to their loved ones and also the community at large. The Pride Center was the first location in the state of Florida to host a community town hall on Mpox. We partnered with the Florida Department of Health in Broward County to offer Mpox vaccination clinics where more than 5,000 vaccinations were administered. These clinics were also able to provide 1,628 meningitis vaccinations, 1,094 hepatitis A vaccinations, and 310 additional Pfizer vaccinations against COVID-19, which was on top of the thousands of COVID-19 vaccinations previously administered during the pandemic. Over the past year, the center has distributed 527 HIV home test kits throughout Florida, 18% of which went to people who indicated they had never tested for HIV before. Additionally, over the last year, the Pride Center has conducted 428 rapid in-person HIV tests on site and 432 throughout Broward County, including sex clubs, pharmacies, and recovery centers. Our community touch is broad with over 9,000 subscribers receiving the Pride Center's digital newsletter emailed each Thursday. In addition, the Pride Center's Facebook page has over 10,000 followers. If you'd like to receive our digital newsletter, we're dropping a link in the chat where you can sign up yourself right now. The center has set several objectives for this town hall, with the overall goal of ensuring we continue to raise awareness and advocate for access to vaccinations and treatment, regardless of your demographics. Our objectives to achieve this goal will be: define syndemic, demonstrate and discuss disparities related to Mpox, clarify how stigma impacts the response to Mpox, define social determinants of health and how they impact healthcare, define status-neutral approach and explain how it can help overall stigma and disparities in healthcare. Understand why Mpox is not a gay disease and that vaccinations are still appropriate. And last but not least, discuss lessons learned for future outbreaks and public health response. On behalf of the Pride Center staff, board of directors, and volunteers, I would like to thank the panelists for giving of their time today to be a part of this event. I also want to thank the CDC Foundation for their generous support of this project. And most importantly, I want to thank you, the participants, for caring enough about yourselves, your loved ones, and your community to show up and be present. And with that, I'd like to turn it back over to our Zoom moderator, Christian.
Thank you, Mr. Booth, for that great overview of the valuable work at the center. And now we will start with hearing from Craig Stafford, a community member in South Florida who has lived firsthand the stigma associated with Mpox and COVID-19. Take it away, Craig.
Greetings, everyone. I just want to first thank the Pride Center for having me on and being able to share my story with the community. The poster that you see before you is a digital art piece that I created to express my experience with monkeypox in a way that was not only creative, but allowed me to convey the message, I guess the word to say, in an easy, light-hearted way. So that is the reason why I created that poster. There is a piece that I wrote as well while I was going through the monkeypox and I had to quarantine. And I'm just going to read a little bit of that really, really quick so you get the depth of what the poster really means. I am a Black man having had Black scabs that left me feeling like the black sheep of society. I am a monkeypox survivor, unlike the three wise monkeys that see no evil, hear no evil, and speak no evil, one covering their eyes, another covering the ears, while the other covers the mouth. I saw, heard, and spoke the name monkeypox for nearly 2 months. My eyes looked upon the painful and hideous big black scab on my genitalia. My Mr. Good Stuff mutated into a crusty lava rock. I was erupting with volcanic eruptions and emotions silently. And that's just a little bit of what I wrote to go along with the digital art piece that I did about monkeypox to express my experience with having monkeypox. And it's weird because at first I thought I had COVID. I was fully vaccinated when I got Delta. So I'm like, oh my God, I can't believe that I'm getting COVID again. I can't believe I'm getting Omicron. And that led me to go to urgent care. The test results came back negative, which led me to go to the ER. And I went to the ER. I told them what I thought it could be. And I told them, I said, based off of what I have seen on the CDC, I believe that I have monkeypox. They examined me. Upon first examination, that's when they quarantined me in the ER. And when they quarantined me, I was like, based off of what they're doing, I think I have it. So they took a culture sample. The culture sample came back positive for monkeypox. And that started my journey with contacting my local health department, which is Broward Health Department, and linking me to making sure that they linked me to my primary care physician. Unfortunately, my primary care physician did not approve me for the treatment because he felt as if it was too experimental. And he said that he was not comfortable taking it if he had it. And so, therefore, he did not authorize me to get the treatment. So I had to go through the initial 4 weeks without a vaccine, without a treatment, the old fashioned way, just allowing it to run its course and my body naturally develop the antibodies. Um, that put me in a very personal situation, very reflective. And I found myself uh, having internal stigma, internal shame, because how can I tell my family, which I did, but how can I tell them the extent of my monkeypox? I didn't have it on my face that you saw on social media or in the news. I didn't have it on my arms. It wasn't visible. So how can I tell them, I have monkeypox? Oh, and by the way, this is where I have it. So now I'm having internal shame. I'm having internal stigma. And the only person that I could talk to was a very, very close friend of mine. So I relied on that friend every day. We had conversations every day. I relied on my spirituality. So I had personal conversations with my ancestors. And I took walks every day that allowed me not to, I was outside in the open, away from people. And so I couldn't get cabin fever. Those are my thoughts. And those were the three things that got me through my experience. Um, so I go through the 4 weeks of quarantine. I'm doing good. A week goes by and monkeypox pops on my face. And I go through another period of quarantine. So I was in quarantine with the monkeypox almost 2 years. Um, as I'm thinking about it, of course, I had to tell my employer. Now, I've had COVID, and I noticed a stark difference between telling my employer that I had COVID and telling my employer that eventually I had to tell my employer I didn't want to. But I told my employer that the reason why I have to be out for so long is because I have monkeypox. With COVID, all thing I had to say to my employer was, I have COVID. Oh, okay, stay home. But for some reason, with monkeypox, it was different. It seemed as if every 2 weeks or every week I had to submit a doctor's note. Um, I just, that added a level of stress to me because it almost felt as if, why am I being treated so differently with monkeypox versus with COVID? It was no questions asked. I didn't have to submit any paperwork. Only thing I had to say is I'm having COVID-like symptoms, or I tested positive, negative, and now I can return back to work. But with the monkeypox, it just seemed as if I had to go through hoops and hurdles, and that added a level of stress, more shame, and more stigma to myself. So it's now a combination of internal stigma and external stigma, internal shame, external shame, while every day I have to take a bath and I have to use the restroom, and I'm seeing this big black scab called the monkeypox. No vaccination, no treatment, just nearly 2 months of just living with monkeypox. Um, I think that's the gist of, I don't want to go on and on, but that's pretty much the gist of my personal experience dealing with the monkeypox. A professional Black man, and I got monkeypox. That's my story. Thank you.
Wow. Thank you, Craig, for sharing your very personal story. We now move on to Dr. Margaret Gorensek, an infectious disease physician practicing at Holy Cross Health in South Florida. She will share some local South Florida information related to Mpox. The floor is yours, Dr. Gorensek.
Okay, thank you very much. Oops. All right, so I was asked just to share with you what our experience at Holy Cross has been when we first started seeing cases of monkeypox. Next slide. So I wanted to review here the total number of cases we had seen in Florida. It started in around May, the first cases started coming in. And by the end of May 6th of this year, this is the total number of cases that have been recorded in Florida, according to the Florida Department of Health website. And of the 2,897 total cases as of May 6th, 907 were in Miami-Dade County, and Broward was second with 725. And then you see the rest: Orange County, 302, 230 in Hillsborough, 165 in Pinellas, and then 122 in Palm Beach. These were the counties that had the most cases, and there were smaller numbers of cases in the other counties. And the way the cases were acquired, the majority of them were acquired in Florida. Some were acquired in the United States, but not in Florida. And about 143 were definitely acquired out of US from travel related, and then unknown about 418. Next slide. If you look at that breakdown by age groups, the majority of cases really were happening around ages 20 up to the 50s, as you can see in the highest number in the 30 through the 40 age range. Next slide. And this is a distribution of cases. You can see how they peaked in the summer of last year. The first cases were reported in May, and then in June, 27, by July, 346, and by August, we peaked at 1,286 cases. And then it started going down as the efforts were successful in getting the word out about risk factors for Mpox, the vaccine availability, and efforts by the health department and community centers such as Pride One in getting the vaccine available. So I know at Holy Cross, we gave around, I think, 2,000 total vaccines, Mpox, and then also for hepatitis A and a meningitis vaccine at the same time. The good news is that I think the efforts at getting the word out about Mpox, the prevention by getting the Mpox, the smallpox vaccine, really led to a significant decrease in cases. So by 2023, there are only small numbers of cases trickling in. So I think that shows that the efforts made by everybody, especially Pride Center, and having the first Mpox town call and making people aware of the risks and how to mitigate it, really made a difference, I think, in decreasing the potential of this disease to really spread even more. Next slide. So a little bit about the cases we saw at Holy Cross Health. The ER saw a lot of them. Most of them actually were able to be discharged. They had the test done in the ER and were sent home. And when confirmed, they were referred to the health department. The demographics and the backgrounds are similar to what the CDC has reported. Most of the cases were in men in the MSM age group. Most, as I said, were 20 to 50 age range. Most of the cases were relatively mild with just skin lesions, some only a few, some more. We did have a number of patients admitted and a couple that were really severe. The one patient I saw who, because the propensity of the lesions to start in the genital area, some of them came in with proctitis. One gentleman came in, couldn't even urinate. His penis was so swollen from the lesions that were on the penis. And the patients that were sick were able to get the TPOXX through the health department. And of course, if they had underlying HIV, they were referred for TPOXX as well. So we did actually have at Holy Cross one of our ER nurses who had a needle stick when she was doing unroofing the vesicle of a patient with a suspected Mpox in the ER, and she accidentally stuck herself when she was recapping the needle. And although she got the vaccine within 24 hours, she later developed one lonely lesion at the site where the needle had stuck, and it was confirmed to be Mpox, but she did well and resolved. And then unfortunately, we had one of the deaths reported, and this patient was really heartbreaking. He came in almost dead already. They found him in drug overdose in a bathtub, and he had skin lesions that was the worst I've ever seen all over him. And it was confirmed Mpox. He died, and the cause of death was determined at autopsy by the medical examiner to be due to complications of disseminated Mpox. So we've seen the spectrum, but the good news is that most of the cases were mild, could be treated, could be followed as an outpatient. Not all of them needed to get the treatment, but when it was needed, we were able to get it with the help of the health department. And I saw a number of patients in my own practice who got it, and most of them had mild cases. If their HIV patients are well controlled, they do as well as anybody else. The cases that we saw, a lot of them that got really sick were people with HIV that was uncontrolled. And that we know is one of the biggest risk factors for severity of cases and from death for Mpox. Next slide. So to summarize a little bit, because HIV and Mpox do interact with each other, HIV patients that are not controlled on meds have a big risk for getting very sick from Mpox. And we've seen patients progress to encephalitis, require hospitalization for severe rash Mpox lesions, especially those that involve critical areas like in the esophagus. They've had cases, now we haven't seen it, but a patient with Mpox that had to be intubated because the swelling from the lesions was so bad that couldn't breathe. We've had patients get urinary retention proctitis from the lesions being in the genital area and the penis. And patients that have the highest risk are those with HIV that is uncontrolled. And one other thing that was noticed in this pandemic, this disease speaking to the interactions with other diseases, is that about a third of patients that did get diagnosed with Mpox were found to have other STDs, underlying the need to test for all STDs and HIV for patients who come in with Mpox. Next slide. And so again, like I summarized, what we've learned from the cases that we've seen is that risk factors for getting a severe case of Mpox, number one, uncontrolled HIV, and then people with skin diseases, underlying atopic dermatitis, psoriasis, eczema, cases of people with acne, and then if you have an infection with herpes or varicella zoster and you get Mpox on top of it, you're at risk to get a more severe case. So again, speaking to the stigma associated with Mpox, I think, although it was initially felt, attributed to being a gay disease, it's really not a gay disease, but it does happen because the risk factor for transmission is a lot of close physical contact. So if you in a situation where you're having a lot of physical contact with people who might have Mpox and not even know it in the early stages, that's why it ended up being in communities like that where you're having close physical contact. So it's not that being gay causes it, it's just close physical contact settings will cause spread of Mpox. And so some of the cases that we've seen were like in households where somebody had it and other people in the household got it because of the close contact. That leads to this, one of the major risk factors for the disease. So, and I know the vaccine effort was very successful, but there was some concerns because when they went to giving the vaccine intradermally, people were getting more skin reactions. And so there was a concern there that a lot of people felt that might be a stigma if they got the vaccine, marking them as being somebody at risk for Mpox. But I think our efforts as all healthcare providers are to treat our patients regardless of, what their background is, where they come from, how they got it, we treat them. And I don't think that we felt any stigma associated with the patients coming in. We did the best we could to help all the patients, but because of the way it started and all that, the concern is, for the disparities where the cases have happened, and the effort is to really educate the community, because that's the number one tool we have to help break down spread of a disease like this, by getting an understanding of how it's spread, what the risk factors are, the fact that there's a vaccine that will help keep people from getting it, and just getting the message out there that we're there for the community, and we do all we can to help the community get the help it needs to prevent this disease from spreading. Hence the vaccine effort, going out to the community, going to where people are with the vaccines made available easily, have made a big difference, I think, so that this disease was able to be controlled by the time we got to 2023, at least in our community here. And similar to the risk groups that we see, there is disparities in where these cases happen, often because just of lack of education, lack of awareness. Just like with HIV, we saw in the beginning cases happening in communities that really didn't have access to understanding what the risk factors were. And when I came down to Florida from the Cleveland, Ohio, with the Cleveland Clinic, I'm trained in both adult and pediatric infectious disease, and I was being called to the hospitals to see these babies coming in at 6 months of age with really bad pneumonia, found to have PCP pneumonia, dying within 6 months to a year, and their moms didn't even know that they had HIV. And it was at that time that we realized that in order to provide care successfully to the babies and the moms, treating them together in a setting where they could get help with all the other things that are important for living, just food, clothing, shelter, would make a big difference in trying to identify the problem. And also when we got to the point that we started testing all pregnant women, regardless whether they had risk factors or not for HIV, we were finally able to prevent transmission to babies, so that now we really hardly ever see a baby being born with HIV, because all women who are pregnant are tested for HIV. And it's the opt-out option where you tell them everybody gets tested this way, so nobody feels like they're being singled out, that they have a stigma if they're asked to be HIV tested. We just offer it universally, and that has made a big difference in turning around some of the disparities that we're seeing.
Thank you, Dr. Garansek, for giving us insight on how Mpox affected us locally here in South Florida. Our final speaker is Dr. Dimitri Daskalakis, Deputy Coordinator, White House National Mpox Response. The floor is all yours, Dr. Daskalakis.
Thank you very much, Christian. And also thank you to Craig for just such an important view of Mpox, not from the statistical perspective or the epidemiologic perspective or the clinical perspective, but the real perspective of what a human feels and what it's like to experience an infection that some people then polarize and give a valence to, that then allows that infection to cause stigma. So really thanks to Craig. And you're not going to be surprised that a lot of what I talk about is going to really harmonize with what Dr. Garansek talked about. Really the national experience and the experience in Florida, I think, are similar, and really many of the same issues as well as the same opportunities arise. Next slide, please. So I'm going to start by just giving a quick overview of where we are with the outbreak, and also make sure that we highlight some new information, given that, again, we do have some new information about some clusters that are being seen in the United States. Next slide, please. So as of May 10th, 2023, there have been 30,395 individuals who have been diagnosed with Mpox. I just want to say right here, always remember, when you see a number, each of those people is someone like Craig. So these are people who experience suffering, who experience stigma. So though we present the numbers, we can't all present the stories, but that really fills out the picture of what this really means. So about 30,395 cases. As you heard from Dr. Goresnik, there was one death that occurred in her facility. There have been 42 deaths so far in the United States. The map that I'm sharing, the darker the blue color, the higher the number of cases diagnosed in that state or jurisdiction. So you can get a sense of where we were seeing most of the activity for Mpox historically since May 2022. Next slide, please. This is the epidemic curve of Mpox in the United States. I'm going to tell you what that means. Epidemic curve, there's a couple of different colors that you may see on the slide. You see that large hump that's made out of individual lines. Each of those lines represents the number of cases that were diagnosed or reported in the United States on that day. The blue line, the dark line that then makes the curve, that little hump, that is the average number of cases per day. So what you can see is, just like what you heard about what happened in Florida, we had a peak of the outbreak sometime in August, and then a slow decrease. And for several months, we had seen lower and lower numbers of infections, and this trend continues. We most recently, in the last week, have heard about a cluster of 13 cases, so people with Mpox in Chicago. And I'm going to go deeper into that, but it's the largest number of cases that we've had for several weeks. So really something that we're watching very carefully. In terms of who's getting Mpox, just like what you heard in Florida, there is a propensity of people that reported Mpox somewhere in that 20 to 50 range. 31 to 35 is the highest bar that we have in terms of ages. Almost all, 95% of people diagnosed with Mpox were cisgender men. Cisgender women made up just under 3%, and transgender men about 0.3%, transgender women about 0.8%, and then the other less than 1% were people who had other gender identities other than transgender or cisgender. Additionally, when you look at the race and ethnicity of who was being diagnosed with Mpox in the United States, there's a pretty consistent proportion. About 60% of the people diagnosed with Mpox were Black and Latino. That really jives with what Craig said. Like, it's not just about their race, it's professional people, it's people who have complex lives, people who have not so complex lives. But there was a propensity toward Black and Latino individuals, which is not about being Black or Latino, but about the sort of disparities that we have in the US across the board. And I'm going to share some views of that in this presentation. Next slide, please. So I want to talk a little bit about where we are with vaccine, as well as the risk for future outbreaks. And we'll also highlight what's happening in Chicago right now. Next slide, please. Quick once more. So this is a model from the CDC that shows what the potential could be if there is, could you please advance once again, sorry. There you go. So this is a model that the CDC has designed to take a look at how much vaccination, how much immunity do we need in the community to prevent an outbreak? And what amount of vaccination do we need in the community to prevent a large outbreak? So what they found was that the more immunity that there is, the less likely it is that we will have an outbreak at all. So higher vaccination, lower risk for outbreak. They also found that if in a community, vaccination rates are less than 35%, there's a risk that if we do have an outbreak, that outbreak will be equal to or bigger than what we experienced in the last year. This really tells us that we still have work to do on vaccinating folks to make sure that we're protected from future outbreaks of Mpox as we see the numbers across the country declining. Next slide, please. So the first question is, just to remind you, who should be vaccinated for Mpox to prevent an infection? Advance one. So gay, bisexual, and other men who have sex with men, and transgender or gender diverse individuals, especially if they have a history of having some risk factors in the last 6 months, like if they have more than one sexual partner, or if they've had a history of a sexually transmitted infection. Click. People who have had sex at sex venues like sex clubs or a bathhouse, or large events or festivals, especially in areas where there might be Mpox transmission. Click, please. People living with HIV, or if they have an other immunocompromising condition, so a weakened immune system for some other reason, and if they have any recent or anticipated exposures. Click, please. Or any of their sex partners. So of all the people that we talked about, their sex partners also qualify for vaccine, and really making sure I highlight that sex workers are on that list. One more click on this slide. And what's important is it's not just about the past, it's also about the future. So if someone is anticipating experiencing any of those above scenarios, and that in this scenario means fun, sometimes in summer happens, and so especially in these populations, make sure that we have offered them vaccine or get them to finish their vaccinations. And also the other important thing is, it's not about seeking out all the details of their lives. If people come and say, I want a vaccine, that's enough to get it. We don't have to do more risk assessment. We don't have to grill people to see if they qualify. If you think you qualify and you present to get the vaccine, you should be able to get it. Next slide, please. So this is where we are with vaccination in the US so far. And again, really special thanks to the Pride Center for being such a leader in Florida and getting so many people vaccinated. We have made a really significant amount of progress in vaccination. About 1.2 million doses of vaccine have been administered in the United States. On that graph, you see that there is a big hump and then it peters off. And that big hump, unfortunately, looks just like our cases. And what we need to see is that we keep increasing vaccine right now so that we can make sure that we have built even more immunity in the community to prevent the possibility of a future outbreak. Next slide, please. And I want to say that also means first and second doses. So I think we already covered this, but the vaccine is a 2-dose vaccine. And so if individuals have only had 1 dose, it is never too late to get that second dose. So if that's you, totally book an appointment, set up a time, go get that second dose to make sure that we really get that force field up as high as possible. Another really important study that the CDC released really shows the disparities that we are seeing in vaccine and the disparities that we see in other areas of prevention. So this graph shows the proportion or the ratio of how many individuals got vaccine when compared to the number of individuals within their race or ethnicity group who had the infection. So what that means is that top line means that for every infection in a white man or a white person, there were 43 white people who were vaccinated for Mpox. For every infection in a Latinx individual, there were 17 Latinx people vaccinated. And for every infection in a Black person, there were 9 people vaccinated for Mpox. When I saw this, I said, wow, this looks really familiar. Click, please, because it looks almost identical to another graph that tells the same story in pre-exposure prophylaxis. Making sure I got that click in there. Click, please. I have a little animation here. Thank you. So this graph is a graph of the ratio between people who are taking PrEP compared to how many cases of HIV there are diagnosed in a year based on their race and ethnicity. The story is similar. You can see that white men have a high proportion of individuals who are on PrEP, while Black and Latino are lower. It really raises the important need for us to focus on equity. And again, the work that you're doing at the Pride Center is so important to making sure that we address this. Really that work in equity to really make sure that we get the vaccines to people and also HIV treatment and prevention to people in a way that is equitable given the burden of disease in their population. So this is just a reminder that we have some very clear issues that continue to hamper our ability to equitably really do any prevention, including vaccines for Mpox. Next slide, please. It's also important to remember that Mpox infection after vaccination can happen. We think that vaccine has an effectiveness of about 70%. That means that it's not perfect. But even when it's not working, it does work. And what I mean by that is people who have the Mpox vaccine, if they become infected with Mpox, tend to have milder disease and don't get hospitalized, and that also prevents death. So it's really important news to remember that it's not just about preventing the infection, but also preventing some of the complications. I'm highlighting a cluster of infections that happened in France. About 17 people were confirmed with Mpox, and many of them had been previously vaccinated. So this cluster quieted down, and I think that that's mainly due to the fact that so many people in the community are vaccinated. So even imperfect immunity in a lot of people is still a lot of immunity in a population. Next slide, please. We're seeing a similar story that's unfolding now in Chicago. 13 cases have been identified to date, 9 of them in previously vaccinated individuals. What we do see in those cases is that their symptoms are very, very mild and that none of them have been hospitalized. So this is really important news. We haven't finished the vaccine job yet. The more we get people vaccinated, the more we prevent infection and also prevent the complications of Mpox. Next click, please. So it's really important, even if you've been vaccinated against Mpox or you've had Mpox in the past, if you have a rash that's concerning, you should get tested for Mpox. Click again. We need to keep vaccinating. If you personally have not been vaccinated, and the story that I told about who needs a vaccine, if you saw yourself in that story, get vaccinated. If you've only had that single first dose, get that second dose so we can increase the protection that it can provide. Also remember, it's not all about preventing the infection. Like I said, it works even when it seems like it doesn't work, because people who have the infection after vaccination don't get as sick and they don't get hospitalized as often. Next, please. Which means that Mpox vaccination is still a really powerful tool to protect personal and public health. And I think we already heard our community steps up. It steps up to getting vaccine, and it also steps up when advice is to really be careful around sexual activity if necessary. So I think right now, what's really important is that we use every tool in our toolkit to make sure that we can prevent Mpox. And number one on that list today is get yourself vaccinated if you haven't done it. And if you haven't gotten 2 doses, get the second dose. Next slide, please. And this now I want to talk about something that's a bit theoretical. And I think Dr. Gorencik actually told the story, but I'm going to tell you the story in a different way. Click, please. I'm going to tell you the story of a syndemic. Syndemics are epidemics that interact with each other, and because of that interaction, increase their adverse effects on the health of a community that faces systemic, structural, and other inequities. Let me give you a picture to tell you what I mean. Click, please. So, in real time, in the last year, we saw Mpox emerge and then interact with HIV, sexually transmitted infections, mental health and drug use, as you heard from Dr. Gorencik. What happens is there are interactions between these infections and other health challenges that make the individual pieces way more powerful. Click. On top of the interactions that are naturally happening between these infections and conditions, social determinants of health, like systemic racism, homophobia, transphobia, and housing instability all come together. And they take this sort of meteorite that's formed between Mpox, HIV, STIs, and it makes it more powerful and more dense. Click, please. And so what is already an interaction between Mpox, HIV, and STIs is made even worse and is fused into a syndemic. Click. And that syndemic actually then has increased synergistic impact, so worse impact on affected communities. So it's not just the HIV or the STI or the Mpox or the mental health issues. They come together, and then all of the social environment that exists that makes inequity really intense makes it worse, and the impact is greater. And I'm going to tell you the story of how Mpox joined this endemic. Click, please. So first, in September 2022, there were data that came out from CDC that showed that 38% of people who were diagnosed with Mpox also had HIV. 41% had had a prior sexually transmitted infection in the last year. So what that starts to tell us is HIV, sexually transmitted infections, and Mpox, they all live in the same zip code. They seem to travel together. But this study started to show us something very important. Click, please. What it showed us was not only was it living in the same zip code, but HIV made Mpox worse. What we found was that people with Mpox and HIV were more likely to report severe symptoms. Click, please. They were more likely to be hospitalized. Click and click. And if they had uncontrolled HIV or later stage HIV, it was more likely that they were going to be hospitalized and have some of the more severe manifestations of Mpox. Next slide. Then in October, CDC released the story of the 57 sickest people with Mpox in the United States. Those are folks that were hospitalized. And that's very similar to the patient that Dr. Goresnik talked about. Those 57 people, 82% had HIV. 72% of those who had HIV had a T cell count less than 50, so the latest stage disease. Only around 10% of them had ever taken HIV medicine. And as I told you about systemic racism and homelessness, those came together and are overrepresented in these people. Almost 70% of the sickest people were Black and 23% were homeless. Some of those people died. And I'm going to share what we learned about the folks who passed away as well, but we can predict what was going to happen based on the hospitalizations. Click, please. Internationally, this also plays out. HIV interacted with Mpox across the globe. Individuals with worse T cells, lower T cells, tended to do worse. They tended to be people who were not on medicines or not in care. And in the international group of patients that were published, all of the people who passed away had T cells less than 200. Next slide, please. Similar data was seen in the United States when the demographic details of the people who passed away from Mpox were shared. Click, please. In this group, what we found was that 87% were Black, 95% were male, and of those who had information with HIV, almost all of them had the most advanced disease with T cells well under 50. Next slide, please. We also found that if you looked at this a different way, that you found the same answer. So in LA, they asked the question, if we look at people with Mpox who are homeless, what do we find about their stories? 60% of the people who were homeless in Los Angeles County who had Mpox had HIV. And only half of them had good control of their HIV or undetectable viral load. Really proving the point. Mpox entered this endemic of HIV. They interact. Homelessness, racism, homophobia, transphobia, all the stigma made that even worse. And the impact on those people within this community was awful. Click, please. And so if you have a syndemic problem, you really have to come up with a syndemic solution. And what some of the work that we did early in the fall, which I think prevented worse outcomes, click please, was that we used Ryan White that takes care of people living with HIV, CDC, HIV prevention, and STD resources, resources for mental health and for drug user health, as well as housing resources to weave together a strategy where we really touched all the parts that were challenging to people who are being diagnosed with Mpox. So these continue. We continue to work with jurisdictions and with local health departments to make sure that all of these resources are being used, since we can see very clearly Mpox does not live in isolation. Click, please. And this fits into a status neutral prevention cycle. So as you heard from Dr. Gorensik, when she talked about the story of pregnant women and how, or pregnant people, and how they're able to create a service that really allows for HIV testing and all the resources that are needed to make sure people are healthy. That's the story behind a status neutral approach, which means that that HIV test opens the door. If someone's negative and they need prevention, we give them the services that they need so they can stay within prevention services. That means that maybe they go on PrEP, and that means that their chance for getting HIV goes way down. Same for people with a new diagnosis of HIV. We provide them the services that they need, whether it's harm reduction or housing, and ultimately that allows them the ability to really focus on their HIV health and get into care, become undetectable, and also don't transmit sexually to their partners. This is really an example of a syndemic solution for a syndemic problem. HIV doesn't live in isolation, Mpox doesn't live in isolation, viral hepatitis doesn't live in isolation, drug use doesn't live in isolation, nor do mental health challenges. So coming up with systems like the one that Dr. Gorensik talked about really allow us to really provide that whole person care to be able to address all these issues. Next slide, please. So now I want to talk about summer and about some of the resources that we have to really stimulate you all to get vaccinated or to tell your friends to get vaccinated. Next slide, please. We have this great website, and the website is not about scary things like Mpox and HIV in a scary way, but about the excitement that we all have in the summer as we're approaching Pride season. And it's really a way for you to learn how you can stay healthy and ready for summer 2023. Click. This website doesn't just talk about sexual health. It talks about travelers' health, what you do if you are traveling to certain outside the US, advice about travel. It also includes all of the sexual health ideas that you can imagine, HIV, STI, Mpox, all of the things that are challenges. It talks about COVID because we're not out of the woods there. People need to be up to date on their vaccine. It talks about Mpox vaccine, the need for 2 doses, and the importance of knowing how to prevent overdose, since that's a challenge that we're seeing across the US as well. So please check this out. It has a lot of information, and it can be your roadmap for how you can make sure that you have a healthy summer that is really geared up for a great Pride season. Next slide, please. We also have a lot of other resources. We have posters for sex clubs. We have palm cards. We have videos that tell you all of the details about vaccines as well as Mpox. And we can see if we can ask our friends at the Pride Center to circulate that all to you, because it's really good information. So please take a look at it, especially if you're thinking, should I get vaccinated? The answer is yes, get 2 doses. Next slide, please. And with that, I think we are at 7:25 Eastern Standard Time, which is, I think, when I am supposed to stop talking. So I'm going to hand it back over to Christian. Thanks, Christian.
Thank you, Dr. Daskalakis. Now that we've heard all the speakers, we will open up the polls to, again, get your post-event responses. Please take a moment to complete this poll, which will help us determine the impact of the information shared tonight. Okay. Alrighty then. If you're local to us here in the Fort Lauderdale area, our next in-person town hall event will be on June 8th at 6:30 p.m. It is a sequel to our Don't Yuck My Yum town hall, which addressed the stigma associated with non-traditional relationships. We will also be offering Mpox and other vaccinations in partnership with Holy Cross Health at this event. We will include registration information for this next town hall, along with the slides from today and other additional information in the post-event email all attendees will receive. On behalf of the Pride Center, we want to thank all the attendees and speakers for their time and for being part of this virtual town hall. Once we end this virtual town hall, you will see a pop-up window on your screens with a feedback survey. We would appreciate it if you can please help us by completing it. Thank you. And this concludes the Facing Mpox, Tackling Stigma virtual town hall. Have a good night.